My name is Dr. Yona Gandhi. I'm going to take you through some cases we prepared for you this evening. So this is case number one. This is a 42-year-old male. He's non-hypertensive for the past 15 years. He has blood pressure that has been controlled on antihypertensive, including Nebivolol 2.5. This man has a history of recurrent palpitations that are lasting for seconds to minutes for the past 3 years. He also reported the history of pre-syncope. The symptoms actually, when it appears, this palpitation tend to interfere with the daily activities, but this patient is not reporting any history of heart failure. So this is the ECG of this patient who is complaining of recurrent palpitation. Basically, what we are seeing here is a sinus rhythm, but if you are careful enough, somewhere you find the R to R interval is not the same. So because the rhythm is sinus, so this is sinus arrhythmia. It is a class 2B indication for a patient actually who is getting unexplained syncope to undergo electrophysiology testing, and where possibly if you find this arrhythmia induced, then to continue with the ablation. So having received this patient actually was taken to the cath lab, and where our approach actually were all sheaths and the catheters, the access on the femoral vein. Now this is the signals that we got from our catheters when the patient was already on the table. Just to orient everyone here is that the white signals are representing the surface ECGs, and this is followed by the intracardiac signals from his catheter, and down there you find there is a green color intracardiac signals. These are coming from the coronary sinus, pole number 1 up to 9 and 10. So we are using the surface electrogram, lead 1 to V1 and V2, to time our events. So here you find that the surface ECG V1, V2 actually is showing the blood QRS complex, and basically this is telling us we are passing from the right ventricle. And here we are using the HIS. The HIS catheter was advanced to the right ventricle, and when we are passing through this catheter, we are getting these blood QRS complexes. And so what we see here is the events. Let's focus on the coronary sinus pole 1 and 2. I will start from there. You find that as we are passing here, the pacing impulse is captured, and you are getting the ventricular signal is a bit hidden within this blue signal here. This actually is followed by the ventricular signal. When this atrial signal, you are passing the ventricle, and that impulse is going to the atrium retrograde. So this is followed again by another impulse, that is ventricular signal on the coronary sinus electrode 1 and 2. This again is the impulse from the ventricle reaches the atrium. There is another ventricular signal here that is followed by ventricular ventricular impulse that is followed by atrial signal. Then from there you find this ventricular signal that is not followed by atrial signal. So basically, if you look careful, you find that this is ventricular, which I'm going to say this V, short form V, and followed by atrial signal, which I'm going to shorten as A. So I'm saying this VA time, again followed by VA time. When you take, much attention, pay much attention here, what you see that the first part of VA time is actually short as compared to the second VA time. So there is a progressive increase in the VA time as you keep passing, and later on as you pass the ventricle, then there is no signal that is captured in the atrium. So what does this mean is that the AV node actually is rendered a slow conduction for each incoming impulse, and this phenomena is called decremental conduction. That is, you are reducing the ability of the AV node to conduct each incoming impulse until it is unable to conduct it. And this is basically a normal AV node conduction. And this is basically information that I wanted to share to you. So here now we are using the coronary sinus, and what we see here is that every time we pass the atrium, this is followed by ventricular signal. This one-to-one, atrium, ventricle, atrium, ventricle, atrium, ventricle. This is one-to-one conduction. Now, this followed actually by, as you go on, you find that this atrial signal that actually is there is followed by V signal, but as you keep pressing on, you find that this atrial signal that is not followed by ventricular signal. So the loss of ventricular signal here is what we call antegrade Wenckebach, because we are pressing the atrium, but there is no capture in the left in the ventricle. So this is called antegrade because we are pressing from above to down. This is called antegrade Wenckebach. So we went on getting some information for intracardiac information on this patient. And actually this time we are seeing again, we are pressing the right atrium and you are getting the ventricle, this one-to-one conduction. Again, here you find the QRS on the surface ECG are blocked. They take the form of left bundle branch block. Actually, this signifies that you are passing from the right ventricle going to the right atrium. So this, as you go, you find this one-to-one conduction there. So now, at one time, we were applying the premature. This is what we call, we are applying a single extra stimulus to the right ventricle. Now, as you can find here, there was, when we applied this extra stimulus, there was ventricular capture that was followed by atrial signal. But as we went on applying more, the next bit, the ventricular signal was not led to the atrium. So here we are saying this is retrograde effective refractory period of the ventricle. So, because going back to the first slide, because there was no one-to-one conduction in this part, that we lost conduction for when we are pressing the right ventricle. What does it tell us is that this patient has got no accessory pathway. And when we are trying to induce premature beats in this patient, actually we don't trigger any tachycardia. So in this patient, we decided to give atropine. After giving atropine, the procedures were repeated sequential as I explained above, and no tachycardia was induced. Then we went on inducing a second extra beat, that is double extra stimulation to both atrium and the ventricle. No jump, no echo beat, and no tachycardia was induced in this patient. So we concluded that this patient had got a normal AV conduction system and no tachycardia was induced. Thank you.